Nursing management during labor and birth. During labor and birth, various techniques are used to assess maternal status. These techniques provide an ongoing source of data to determine the woman's response and her progress in labor. Vital signs are assessed, including temperature, blood pressure, pulse, respiration, and pain. Also, the prenatal record is reviewed to identify possible risk factors that may contribute to a decrease in uteroplacental circulation during labor. If there is no vaginal bleeding upon admission, a vaginal examination is performed to assess cervical dilation, after which it is monitored periodically to assess progress. Vaginal examination. Vaginal examination is done to determine cervical dilation and effacement. The woman is typically on her back during this examination, and it is performed gently with concern for the woman's comfort. After donning sterile gloves, the examiner inserts his or her index and middle fingers into the vaginal introitus. Next, the cervix is palpated to assess dilation, effacement, and position. If the cervix is open to any degree, the fetal presenting part, fetal position, station, and presence of molding can be assessed. In addition, the membranes can be evaluated as intact, bulging, or ruptured. At the conclusion of the vaginal examination, these findings are discussed with the woman and her partner to bring them up to date about the progress. In addition, these findings are documented either electronically or in writing and reported to the primary healthcare professional in charge of the case. Cervical dilation and effacement. The amount of cervical dilation or opening and the degree of cervical effacement or thinning are key areas assessed during the vaginal examination. The width of the cervical opening determines dilation, and the length of the cervix assesses effacement. When the cervical canal is 2 centimeters long, it is considered to be 0% effaced. A 50% effacement is when the cervical canal reaches 1 centimeter in length. A 100% cervical effacement is when the cervical canal is no more or is paper thin. Dilation of 0 centimeters is when the external cervical os is closed. When the external cervical os is halfway dilated, it is 5 centimeters dilation, and a dilation of 10 centimeters is when the external os is fully dilated and ready for birth passage. The information yielded by vaginal examination serves as a basis for determining which stage of labor the woman is in and what her ongoing care should be. Fetal descent and presenting part. In addition to cervical dilation and effacement findings, the vaginal examination can also determine fetal station and presenting part. During the vaginal examination, the gloved index finger is used to palpate the fetal skull, if in vertex position, or the buttocks in the case of a breech presentation. Station is assessed in relation to the maternal ischial spines and the presenting fetal part. These spines are not sharp, but rather blunted prominences at the mid-pelvis. The ischial spines serve as landmarks and have been designated as 0 station. If the presenting part is palpated higher than the maternal ischial spines, a negative number is assigned. If the presenting fetal part is below the maternal ischial spines, a positive number is assigned, denoting how many centimeters below 0 station. Progressive fetal descent from -5 to +4 is the expected norm during labor, moving downward from negative stations to 0 station to the positive stations in a timely manner. If progressive fetal descent does not occur, a disproportion between the maternal pelvis and the fetus may exist and must be investigated. Rupture of membranes. The integrity of the membranes can be determined during the vaginal examination. Typically, if intact, the membranes will be felt as a soft bulge that is more prominent during a contraction. If the membranes have ruptured, the woman may have reported a sudden gush of fluid. Membrane rupture can also occur as a trickle of fluid. When membranes rupture, the primary focus should be on assessing the fetal heart rate, First, to identify a deceleration, which might indicate a cord compression secondary to cord prolapse. If the membranes are ruptured when the woman comes to the hospital, the healthcare professional should ascertain when it occurred. Prolonged rupture of membranes increase the risk of infection as a result of ascending vaginal organisms for both mother and fetus. Signs of intrauterine infection to be alert for include maternal fever, fetal and maternal tachycardia or fast heart rate, foul odor of vaginal discharge, and an increase in white blood cell count. To confirm that membranes have ruptured, a sample of fluid is taken from the vagina via a nitrazine swab to determine the fluid's pH. Vaginal fluid is acidic, whereas amniotic fluid is alkaline and turns the nitrazine swab blue. Sometimes, however, false positive results can occur, especially in women experiencing a large amount of bloody show because blood is alkaline. The membranes are most likely intact if the nitrazine swab remains yellow to olive green with a pH between 5 and 6. The membranes are probably ruptured if the nitrazine swab turns blue-green to deep blue with a pH ranging from 6.5 to 7.5. If the nitrazine test is inconclusive, an additional test, called the Fern test, can be used to confirm rupture of membranes. With this test, a sample of vaginal fluid is obtained, applied to a microscope slide, and then allowed to dry. Using a microscope, the slide is then examined for a characteristic Fern pattern that indicates the presence of amniotic fluid. Assessing uterine contractions. The primary power of labor is uterine contractions, which are involuntary. Uterine contractions increase intrauterine pressure, causing tension on the cervix. This tension leads to cervical dilation and thinning, which in turn eventually forces the fetus through the birth canal. Normal uterine contractions have a contraction or systole phase and a relaxation or diastole phase. The contraction resembles a wave moving downward to the cervix and upward to the fundus of the uterus. Each contraction starts with a building up or increment, gradually reaching an acme or peak intensity, and then letting down or decrement. Each contraction is followed by an interval of rest, which ends when the next contraction begins. At the acme or peak of contraction, the entire uterus is contracting, with the greatest intensity at the fundal area. The relaxation phase follows and occurs simultaneously throughout the uterus. Uterine contractions during labor are monitored by palpation and by electronic monitoring. Assessment of the contractions includes frequency, duration, intensity, and uterine resting tone. Uterine contractions with an intensity of 30 millimeters of mercury or greater initiate cervical dilation. During active labor, this intensity usually reaches between 50 to 80 millimeters of mercury, and resting tone is normally between 5 and 10 millimeters of mercury during early labor and between 12 and 18 millimeters of mercury during active labor. To palpate the fundus for contraction intensity, you can place the pads of your fingers on the fundus and describe how it feels. If it feels soft, like the tip of your nose, the contraction is considered mild. If it feels like a chin, it's moderate. Or, if it feels like a forehead with little give, it is strong. The second method used to assess the intensity of uterine contractions is electronic monitoring, either internal or external. Both methods provide a reasonable measurement of the intensity of uterine contractions. Performing Leopold's maneuvers. Leopold's maneuvers are a method for determining the presentation, position, and lie of the fetus through the use of 4 specific steps. This method involves inspection and palpation of the maternal abdomen as a screening assessment for malpresentation. A longitudinal lie is expected, and the presentation can be a cephalic, breech, or shoulder. Each maneuver answers a question. What fetal part, head or buttocks, is located in the fundus or top of the uterus? On which maternal side is the fetus's back located? What is the presenting part? Is the fetus's head flexed and engaged in the pelvis? Fetal assessment during labor and birth. A fetal assessment identifies well-being or signs that indicate compromise. Fetal assessment focuses primarily on determining the fetal heart rate pattern. Umbilical cord blood analysis and fetal scalp stimulation are additional assessments that may be performed as necessary in the case of a questionable fetal heart rate pattern. Analysis of amniotic fluid. Amniotic fluid should be clear when the membrane ruptures. When done artificially, a disposable plastic hook, called an amni-hook, is used to perforate the amniotic sac. This is known as an amniotomy. Cloudy or foul-smelling amniotic fluid indicates an infection. Green fluid may indicate that the fetus has passed meconium, secondary to transient hypoxia, prolonged pregnancy, cord compression, intrauterine growth restriction, maternal hypertension, diabetes, or chorioamnionitis. However, this is considered a normal occurrence if the fetus is in a breech presentation. If it is determined that the meconium-stained amniotic fluid is due to fetal hypoxia, the maternal and pediatric teams work together to prevent meconium aspiration syndrome. This would necessitate suctioning after the head is born, before the infant takes its first breath, and perhaps direct tracheal suctioning after birth if the APGAR score is low. In some cases, amnioinfusion, which is the introduction of warmed, sterile, normal saline solution, or Ringer's lactate solution into the uterus, is used to dilute moderate to heavy meconium released in utero to assist in preventing meconium aspiration syndrome. Analysis of fetal heart rate. Analysis of the fetal heart rate is one of the primary evaluation tools used to determine fetal oxygen status indirectly. The fetal heart rate assessment can be done intermittently using a fetoscope or a Doppler, or continuously using an electronic fetal monitor applied externally or internally. Intermittent fetal heart rate monitoring. Intermittent fetal heart rate monitoring involves the oscillation via a fetoscope or a handheld Doppler device that uses ultrasound waves that bounce off the fetal heart, producing echoes or clicks that reflect the fetal heart rate. Traditionally, a fetoscope was used to assess fetal heart rate, but the handheld Doppler device has been found to have a greater sensitivity than the fetoscope. Thus, at present, it is exclusively used in most clinical settings. Intermittent fetal heart rate monitoring allows the woman to be mobile in the first stage of labor. She is free to move around and change positions at will, since she is not attached to a stationary electronic fetal monitoring tool. However, intermittent monitoring does not provide a continuous fetal heart rate recording and does not document how the fetus responds to the stress of labor. The best way to assess fetal well-being would be to start listening to the fetal heart rate at the end of one contraction so that the decelerations could be detected. However, the pressure of the device during a contraction is uncomfortable and can distract the woman from using her paced breathing patterns. Intermittent fetal heart rate oscillations can be used to detect fetal heart rate baseline and rhythm along with changes from baseline. However, it cannot detect variability and types of decelerations as electronic fetal monitoring can. During intermittent oscillation, to establish a baseline, the fetal heart rate is assessed for a full minute after a contraction. From then on, listening for 30 seconds and multiplying the value by 2 is sufficient. If the woman experiences a change in the condition during labor, oscillation assessments should be more frequent. Changes in condition include ruptured membranes or the onset of bleeding. In addition, more frequent assessments occur after periods of ambulation, a vaginal examination, administration of pain medications, or other clinically important events. The fetal heart rate is heard most clearly at the fetal back. In a cephalic presentation, the fetal heart rate is best heard in the lower quadrant of the maternal abdomen. In a breech position, it is heard at or above the level of the maternal umbilicus. As labor progresses, the fetal heart rate location will change accordingly as the fetus descends into the maternal pelvis. To ensure that the maternal heart rate is not confused with the fetal heart rate, a nurse will palpate the client's radial pulse simultaneously while the fetal heart rate is being oscillated through the abdomen. The following are the recommended guidelines for assessing fetal heart rate. An initial 10 to 20 minute continuous fetal heart rate assessment should be performed upon entry into the labor and birthing area. There should be a completion of prenatal and labor risk assessments on all clients. Intermittent oscillations should occur every 30 minutes during active labor for low-risk women and every 15 minutes for high-risk women. During the second stage of labor, assessment should be done every 15 minutes for low-risk women and every 5 minutes for high-risk women. Continuous electronic fetal monitoring. Electronic fetal monitoring, or EFM, uses a machine to produce a continuous tracing of the fetal heart rate. When the monitoring device is in place, a sound is produced with each heartbeat. In addition, a graphic record of the fetal heart rate pattern is produced. The primary objective of electronic fetal monitoring is to provide information about fetal oxygenation and to prevent fetal injury that could result from impaired fetal oxygenation during labor. The purpose of electronic fetal monitoring is to detect fetal heart rate changes early before they are prolonged and profound. Fetal hypoxia is demonstrated in a heart rate pattern change and is by far the most common etiology of fetal injury and death. This continuous monitoring, however, can limit maternal movement and encourage the woman to lie in a supine position, which reduces placental perfusion. Despite criticisms, electronic fetal monitoring remains an accurate method for determining fetal health status by providing a moment-to-moment printout of the fetal heart rate status. Continuous electronic fetal monitoring can be performed externally with the equipment attached to the maternal abdominal wall, or internally with the equipment attached to the fetus itself. Both methods provide a continuous printout of the fetal heart rate, but they do differ in their specificity. Continuous external monitoring. In external or indirect monitoring, 2 ultrasound transducers are applied around the woman's abdomen. External monitoring can be used while membranes are still intact and the cervix is not yet dilated, but can also be used with ruptured membranes and a dilating cervix. It's non-invasive and can detect relative changes in abdominal pressure between uterine resting tone and contractions. External monitoring also measures the approximate duration and frequency of contractions, providing a permanent record of fetal heart rate. External monitoring, however, can restrict the mother's movements. It also cannot detect short-term variability. Continuous internal monitoring is usually indicated for women or fetuses that are considered to be at high risk. Possible conditions might include multiple gestation, decreased fetal movement, abnormal fetal heart rate on oscillation, intrauterine growth restriction, maternal fever, preeclampsia, dysfunctional labor, preterm birth, or medical conditions such as diabetes or hypertension. It involves the placement of a spiral electrode into the fetal presenting part, usually the head, to assess the fetal heart rate, and a pressure transducer placed internally within the uterus to record uterine contractions. Both the fetal heart rate and the duration and interval of uterine contractions are recorded on the graph paper. This method permits evaluation of baseline heart rate and changes in rate and pattern. 4 specific criteria must be met for this type of monitoring to be used. Ruptured membranes, cervical dilation of at least 2 centimeters, a presenting fetal part low enough to allow placement of a scalp electrode, and a skilled practitioner available to insert a spiral electrode. Compared to external monitoring, continuous internal monitoring can accurately detect both short-term changes and variability, along with fetal heart rate dysrhythmias. In addition, maternal position changes and movement do not interfere with the quality of the tracing. Determining fetal heart rate patterns. Assessment parameters of the fetal heart rate include baseline fetal heart rate and variability, presence of accelerations, periodic or episodic decelerations, and changes or trends of the fetal heart rate patterns over time. The nurse should be able to interpret the various parameters to determine if the fetal heart rate's pattern is a Category 1, Category 2, or Category 3. A fetal heart rate which is a Category 1 is one that is strongly predictive of normal fetal acid-base status at the time of observation and needs no intervention. A Category 2 is one that is not predictive of abnormal fetal acid-base status, but does require evaluation and continued monitoring. A Category 3 would be predictive of abnormal fetal acid-base status at the time of observation and requires prompt evaluation and intervention, such as giving maternal oxygen, changing maternal position, discontinuing labor augmentation medication, or treating maternal hypotension. In a Category 1 or normal heart rate, the baseline rate is between 110 to 160 beats per minute. The baseline variability is moderate. Accelerations are present or absent, and early decelerations may be present or absent as well, but there are no late or variable decelerations. In a Category 2, fetal tachycardia of 160 beats per minute or more is present. Bradycardia, with a heart rate below 110 beats per minute, which is not accompanied by absent baseline variability. Absent baseline variability is not accompanied by recurrent decelerations. A minimal or marked variability is observed. Recurrent late decelerations are observed with moderate baseline variability. Recurrent variable decelerations accompanied by minimal or moderate baseline variability, including overshoots or shoulders, along with prolonged decelerations of over 2 minutes but less than 10 minutes. Category 3 or abnormal fetal heart rate assessment is predictive of abnormal fetal acid-base status. In this condition, the fetal bradycardia is below 110 beats per minute, with recurrent late decelerations and recurrent variable decelerations. Baseline fetal heart rate. Baseline fetal heart rate refers to the average fetal heart rate that occurs during a 10-minute segment that excludes periodic or episodic rate changes, such as tachycardia or bradycardia. It is assessed when the woman has no contractions and the fetus is not experiencing episodic fetal heart rate changes. The normal baseline fetal heart rate ranges from 110 to 160 beats per minute. Fetal bradycardia occurs when the fetal heart rate is below 110 beats per minute and lasts 10 minutes or longer. It can be the initial response of a healthy fetus to asphyxia. Causes of fetal bradycardia might include fetal hypoxia, prolonged maternal hypoglycemia, fetal acidosis, administration of analgesic drugs to the mother, hypothermia, anesthetic agents or epidurals, maternal hypotension, fetal hypothermia, prolonged umbilical cord compression, and fetal congenital heart block. Bradycardia may be benign if it is an isolated event, but it is considered an ominous sign if it is accompanied by a decrease in baseline variability and late decelerations. Fetal tachycardia is a baseline of a fetal heart rate greater than 160 beats per minute that lasts for 10 minutes or longer. It can represent an early compensatory response to asphyxia. Other causes of fetal tachycardia include fetal hypoxia, maternal fever, maternal dehydration, amnionitis, drugs such as cocaine, amphetamines, or nicotine, maternal hypothyroidism, maternal anxiety, fetal anemia, prematurity, fetal infection, chronic hypoxemia, congenital anomalies, fetal heart rate, and fetal arrhythmias. Fetal tachycardia is considered an ominous sign if it is accompanied by a decrease in variability and late decelerations. Baseline variability. Baseline variability is defined as irregular fluctuations in the baseline of the fetal heart rate. This is measured from the amplitude of one peak to the trough. It represents the interplay between the parasympathetic and sympathetic nervous systems. This consistent interplay on fetal heart rate from the parasympathetic and sympathetic systems produces a moment-to-moment change in the fetal heart rate. Because variability is in essence the combined results of autonomic nervous system branch functions, it represents the fact that both branches are working and receiving adequate oxygen. This variability is one of the most important characteristics of the fetal heart rate. Variability is described in 4 categories as follows: absent, minimal, moderate, and marked. Absent is when the fluctuation range is undetectable. Minimal is when the fluctuation range is observed at less than 5 beats per minute. Moderate or normal is when the fluctuation ranges from 6 to 25 beats per minute. Marked fluctuations are when the range is above 25 beats per minute. Absent or minimal variability typically is caused by fetal acidemia, secondary to uteroplacental insufficiency, cord compression, a preterm fetus, maternal hypotension, uterine hyperstimulation, abruptio placenta, or fetal dysrhythmia. Interventions to improve uteroplacental blood flow and perfusion through the umbilical cord include lateral positioning of the mother, increasing the IV fluid rate to improve maternal circulation, administering oxygen at 8 to 10 liters per minute by mask, considering internal fetal monitoring, documenting findings, and reporting to the healthcare provider. Preparation for a surgical birth may be necessary if no changes occur after attempting these interventions. Moderate variability indicates the autonomic and central nervous systems of the fetus are well developed and well oxygenated. It is considered a good sign of fetal well-being and correlates with the absence of significant metabolic acidosis. Fetal heart rate variability is an important clinical indicator that is predictive of fetal acid-base balance and cerebral tissue perfusion. It is influenced by fetal oxygenation status, cardiac output, and drug effects. As the central nervous system is desensitized by hypoxia and acidosis, the fetal heart rate decreases until a smooth baseline pattern appears. Loss of variability may be associated with a poor outcome. Periodic baseline changes. Periodic baseline changes are temporary, recurrent changes made in response to a stimulus, such as a contraction. The fetal heart rate can demonstrate patterns of acceleration or deceleration in response to most stimuli. Fetal accelerations are transitory, abrupt increases in the fetal heart rate above the baseline that lasts less than 30 seconds from onset to peak. They are associated with sympathetic nervous stimulation and are visually apparent with elevations of the fetal heart rate of more than 15 beats per minute above the baseline. Their duration is more than 15 seconds but less than 2 minutes. They are generally considered reassuring and require no interventions. Accelerations denote fetal movement and fetal well-being and are the basis of non-stress testing. A deceleration is a transient fall in the fetal heart rate caused by stimulation of the parasympathetic nervous system. Decelerations are described by their shape, and association to a uterine contraction. They are classified as early, late, and variable only. Early decelerations are visually apparent, usually symmetrical, and characterized by a gradual decrease in the fetal heart rate, in which the nadir, or lowest point, occurs at the peak of the contraction. They rarely decrease more than 30 to 40 beats per minute below the baseline. Typically, the onset, nadir, and recovery of the deceleration occur at the same time as the onset, peak, and recovery of the contraction, respectively. They are most often seen during the active stage of any normal labor, during pushing, crowning, or vacuum extraction. They are thought to be the result of the fetal head being compressed, resulting in a reflex vagal response with a resultant slowing of the fetal heart rate during uterine contractions. Early decelerations are not indicative of fetal distress and do not require intervention. Late decelerations are visually apparent, usually symmetrical, and transitory, that occur after the peak of the contraction. The fetal heart rate does not return to baseline levels until well after the contraction has ended. Delayed timing of the deceleration occurs with the nadir of the uterine contractions. Late decelerations are associated with uteroplacental insufficiency, which occurs when blood flow within the intervillous space is decreased to the extent that fetal hypoxia or myocardial depression exists. Conditions that may decrease uteroplacental perfusion with resultant decelerations include maternal hypotension, gestational hypertension, placental aging secondary to diabetes and post-maturity, hyperstimulation via oxytocin infusion, maternal smoking, anemia, and cardiac disease. They imply some degree of fetal hypoxia. Recurrent or intermittent late decelerations are always Category 2 or indeterminate, whereas Category 3 is abnormal, regardless of the depth of the deceleration. Acute episodes with moderate variability are more likely to be correctable, whereas chronic episodes with loss of variability are less likely to be correctable. Variable decelerations present as visually apparent abrupt decreases in fetal heart rate below baseline and have an unpredictable shape on the baseline. These features may also be inconsistent with uterine contractions. The shape of variable decelerations may be a U, V, or W shape, or they may not resemble any pattern. Variable decelerations usually occur abruptly with quick deceleration. They are the most common deceleration pattern found in the laboring woman and are usually transient and correctable. Variable decelerations are associated with cord compression. However, they are classified as either Category 2 or 3, depending on the accompanying change in baseline variability. The pattern of variable deceleration, consistently related to contractions with a slow return to fetal heart rate baseline, warrants further monitoring and evaluation. Prolonged decelerations are abrupt fetal heart rate declines of at least 15 beats per minute that last longer than 2 minutes but less than 10. The rate usually drops to less than 90 beats per minute. Many factors are associated with this pattern, including prolonged cord compression, abruptio placenta, cord prolapse, supine maternal position, vaginal examination, fetal blood sampling, maternal seizures, regional anesthesia, or uterine rupture. Prolonged decelerations can be remedied by identifying the underlying cause and correcting it. A sinusoidal pattern is described as having visually apparent, smooth, sine wave-like undulating patterns in the fetal heart rate baseline with a cycle frequency of 3 to 5 beats per minute, persisting more than 20 minutes. It is attributed to the arrangement of central nervous system control of fetal heart rate and occurs when a severe degree of hypoxia, second to fetal anemia and hypovolemia, is present. it is always considered a Category 3 pattern, and to correct it, a fetal intrauterine transfusion is needed. Category 2 and 3 patterns are more significant if they are mixed, persist for a long period of time, or have frequent prolonged late decelerations, absent or minimal variability, bradycardia or tachycardia, and prolonged variable decelerations lower than 60 beats per minute. The likelihood of fetal compromise is increased if Category 2 and 3 patterns are associated with decreased baseline variability or abnormal contraction patterns. Umbilical cord blood analysis. Neonatal and childhood mortality and morbidity, including cerebral palsy, are often attributed to fetal acidosis, as defined by low cord pH at birth. Umbilical cord blood acid-base analysis drawn at birth provides an objective method of evaluating a newborn's condition of intrapartum hypoxia and acidemia. This test is considered the most reliable indication of fetal oxygenation and acid-base condition at birth. The normal mean pH value is between 7.2 and 7.3. The pH values are useful for planning interventions for the newborn with low 5-minute APGAR scores, severe intrauterine growth restriction, Category 2 and 3 patterns during labor, umbilical cord prolapse, uterine rupture, maternal fever, placental abruption, meconium-stained amniotic fluid, and post-term births. The interventions needed for compromised newborns might include providing an optimal extrauterine environment, fluids, oxygen, medications, and other treatments. Fetal scalp stimulation. An indirect method used to evaluate fetal oxygenation and acid-base balance is fetal scalp stimulation and vibroacoustic stimulation. If the fetus does not have adequate oxygen reserves, carbon dioxide builds up, leading to acidemia and hypoxemia. These metabolic states are reflected in abnormal fetal heart rate patterns, as well as fetal inactivity. Fetal stimulation is performed to promote fetal movement with the hope that fetal heart rate accelerations will accompany the movement. Fetal movement can be stimulated with a vibroacoustic stimulator or artificial larynx. This is applied to the woman's lower abdomen and turned on for a few seconds to produce a sound and vibration, or by placing a gloved finger on the fetal scalp and applying firm pressure. A well-oxygenated fetus will respond when stimulated by moving in conjunction with an acceleration of 15 beats per minute above baseline, lasting about 15 seconds. This fetal heart rate acceleration reflects a pH of more than 7 and a fetus with an intact central nervous system. Fetal scalp stimulation is not done if the fetus is preterm or if the woman has an intrauterine infection, a diagnosis of placenta previa, or a fever. If no acceleratory response by the fetus is exhibited with either scalp stimulation or vibroacoustic stimulation, further evaluation of the fetus is warranted. Pain during labor is a universal experience. The physical causes of pain during labor include cervical stretching, hypoxia of uterine muscles due to a decrease in perfusion during contractions, pressure on the urethra, bladder, and rectum, and distension of muscles of the pelvic floor. The techniques used to manage the pain of labor vary. Today, women have many safe non-pharmacological and pharmacological choices for pain management during labor and birth. These may be used separately or in combination with one another. Pain management standards issued by the Joint Commission mandate that pain be assessed in all clients admitted to the healthcare facility. Non-pharmacological measures. Non-pharmacological measures may include continuous labor support, hydrotherapy, ambulation and position changes, acupuncture and acupressure, attention focusing and imagery, therapeutic touch and massage, breathing techniques, and a fleurage. Most of these methods are based on the gate control theory of pain, which proposes that local physical stimulation can interfere with pain stimuli by closing a hypothetical gate in the spinal cord. This blocks pain signals from reaching the brain. These measures are usually simple, safe, and inexpensive to use. Many of these measures are taught in childbirth classes, and women should be encouraged to try a variety of methods prior to real labor. Hydrotherapy. Hydrotherapy is a non-pharmacologic measure that may involve showering or soaking in a regular tub or whirlpool bath. A wide range of hydrotherapy options are available, from ordinary bathtubs to whirlpool baths and showers, combined with low lighting and music. Many hospitals provide showers and whirlpool baths for laboring women. However, hydrotherapy is more commonly practiced in birthing centers managed by midwives. The recommendation for initiating hydrotherapy is that women be in active labor, more than 5 centimeters dilated, to prevent the slowing of labor contractions secondary to muscular relaxation. The woman's membranes can be intact or ruptured. Women are encouraged to stay in the bath or shower as long as they feel comfortable. The water temperature should not exceed body temperature. The potential risks associated with hydrotherapy include hyperthermia, hypothermia, changes in maternal heart rate, fetal tachycardia, and unplanned underwater birth. The benefits include reducing pain, relieving anxiety, and promoting a sense of control during labor. Ambulation and position changes. Changing position frequently, every 30 minutes or so, from sitting to walking, kneeling, standing, lying down, getting on hands and knees, and using a birthing ball helps to relieve pain. Position changes may also help to speed labor by adding the benefits of gravity and changing the shape of the pelvis. Allowing the woman to obtain a position of comfort frequently facilitates a favorable fetal rotation by altering the alignment of the presenting part with the pelvis. As the mother continues to change positions based on comfort, the optimal presentation is afforded. Supine positions should be avoided, since they may interfere with the labor progress and can cause compression of the vena cava and decrease blood return to the heart. Swaying from side to side, rocking, or other rhythmic movements may also be comforting. Acupuncture and acupressure. Acupuncture and acupressure can be used to relieve pain during labor. Acupuncture involves stimulating key trigger points with needles. Acupressure involves the application of a firm finger or massage to reduce the pain sensation. Holding and squeezing the hand of a woman in labor may trigger the point most commonly used for both of these techniques. Pressure along the side of the spine can help relieve back pain during labor. Application of heat and cold. Superficial applications of heat or cold in various forms are popular with laboring women. They are easy to use, inexpensive, require no prior practice, and have a minimal negative effect when used properly. Heat is typically applied to the woman's back, lower abdomen, groin, or perineum. Heat sources include a hot water bottle, heated rice-filled socks, warm compress, electric heating pad, warm blanket, and a warm bath or shower. In addition to being used for pain relief, heat is used to relieve chills or trembling, decrease joint stiffness, reduce muscle spasms, and increase connective tissue extensibility. Cold therapy, or cryotherapy, is usually applied on the woman's back, chest, or face during labor. Forms of cold include a bag or surgical glove filled with ice, a frozen gel pack, or a washcloth. Breathing techniques. Breathing techniques are effective in producing relaxation and pain relief. If the woman is concentrating on slow-paced rhythmic breathing, she is not likely to focus on the contraction pain. Breathing techniques are often taught in childbirth education classes. Benefits of practicing patterned breathing include breathing becomes an automatic response to pain. Breathing increases relaxation and can be used for dealing with life's everyday stresses. The steady rhythm of breathing is calming during labor. Breathing provides a sense of well-being and a measure of control. Breathing brings purpose to each contraction, making them more productive. And breathing provides more oxygen for both the mother and the fetus. Many couples learned paced breathing during their childbirth education classes. 3 levels may be taught, each beginning and ending with a cleansing breath. The first pattern, also known as slow-paced breathing, is when the woman inhales slowly through her nose and exhales through pursed lips. The breathing rate is typically 6 to 9 breaths per minute. In the second pattern, also known as shallow or modified paced breathing, the woman inhales and exhales through her nose at a rate of 4 breaths every 5 seconds. The rate can be accelerated to 2 breaths per second to assist in relaxation. The third pattern, called patterned paced breathing, is similar to modified paced breathing except that the breath is punctuated every few breaths by a forceful exhalation through pursed lips. All breaths are kept equal and rhythmic and can increase as contractions increase in intensity. Pharmacological measures. Pharmacological pain relief during labor includes systemic analgesia and regional or local anesthesia. Neuraxial analgesia or anesthesia is the administration of analgesic opioids or anesthetics, which produce a loss of sensation in an area of the body. These can be used either continuously or intermittently and are injected into the epidural or into the intrathecal space to relieve pain. Epidural analgesia, spinal analgesia, and combined spinal epidural analgesia has replaced traditional epidural for labor. Neuraxial analgesia does not interfere with the progress or outcome of labor. There is no need to withhold these agents until active labor starts. This shift in pain management techniques allows a woman to be an active participant in labor. Systemic analgesia. Systemic analgesia involves the use of one or more drugs administered orally, intramuscularly, or intravenously. They become distributed throughout the body via the circulatory system. Depending upon which administration method is used, the therapeutic effect of pain relief can occur within minutes and lasts for several hours. The most important complication associated with the use of this class of drugs is respiratory depression. Therefore, women given these drugs require careful monitoring. Opioids given close to the time of birth can cause central nervous system depression in the newborn, necessitating the administration of naloxone or Narcan to reverse the depressant effects of the opioids. Several drug categories may be used for systemic analgesia. Opioids such as butorphanol or Statal, nalbuphine or Nubain, meperidine or Demerol, morphine, or fentanyl, otherwise known as sublamanes. Atoractics such as hydroxyzine or Vistaril, promethazine or Phenergan, or prochlorperazine, also known as Compazine. Benzodiazepines such as diazepam or Valium, or midazolam or Versed. Opioids decrease the transmission of pain impulses by binding to receptor site pathways that transmit the pain signals to the brain. The effect is increased tolerance to pain and respiratory depression related to a decrease in sensitivity to carbon dioxide. All opioids are good analgesics. However, respiratory depression can occur in the mother and fetus depending upon the dosage given. They may also cause a decrease in fetal heart rate variability. The fetal heart rate pattern change is usually transient. Other systemic side effects include nausea, vomiting, pruritus, delayed gastric emptying, drowsiness, hypoventilation, and newborn depression. To reduce the incidence of newborn depression, birth should occur within 1 hour or after 4 hours of administration to prevent the fetus from receiving the peak concentration. Opioid antagonists such as naloxone or Narcan are given to reverse the effects of the central nervous system depression, including respiratory depression caused by opioids. Opioid antagonists are also used to reverse the side effects of neuraxial opioids, such as pruritus, urinary retention, nausea, and vomiting, without significantly decreasing analgesia. Antiemetics. The antiemetic group of medications is used in combination with an opioid to decrease nausea and vomiting and to lessen anxiety. These drugs potentiate the effectiveness of the opioid so that a lesser dose can be given. They may also be used to increase sedation. Promethazine can be given by IV, but hydroxyzine must be given by mouth or intramuscular injection. Neither drug affects the progress of labor, but either may cause a decrease in fetal heart rate variability and possible newborn depression. Compazine is typically given either through the IV or intramuscularly with morphine sulfate for sleep during a prolonged latent phase. It counteracts the nausea associated with opioids. Benzodiazepines. Benzodiazepines are used for minor tranquilizing and sedative effects. Valium is also given to stop seizures resulting from eclampsia. Lorazepam can also be used as it has a tranquilizing effect, but increased sedation is experienced with this medication. Versed, also given by IV, produces good amnesia but no analgesia. It is most commonly used as an adjunct for anesthesia. Diazepam and midazolam cause central nervous system for both the woman and the newborn. Regional anesthesia or analgesia. Regional analgesics, or anesthesia, provides pain relief without the loss of consciousness. It involves the use of local anesthetic agents with or without added opioids to bring about pain relief or numbness through the drug's effects on the spinal cord and nerve roots. Typically, there is a partial or complete loss of pain sensation below T8 to T10 levels of the spinal cord. Epidural analgesia. Epidural analgesia for labor and birth involves the injection of a local anesthetic agent, such as lidocaine, and an opioid analgesic, such as morphine or fentanyl, into the lumbar epidural space. A small catheter is passed through the epidural needle to provide continuous access to the epidural space for maintenance of analgesia throughout labor and birth. Epidural analgesia does increase the duration of the second stage of labor and may increase the rate of instrument-assisted vaginal deliveries. Approximately 60% of laboring women in the United States receive an epidural for pain relief during labor. In urban areas, many hospitals approach 90% use of these epidurals. When the epidural is properly performed, the woman remains in an awakened and almost pain-free state throughout the entire process of labor and birth. An epidural involves the injection of a drug into the epidural space, which is located outside the dura mater between the dura and spinal canal. The epidural space is typically entered through the third and fourth lumbar vertebrae with a needle, and a catheter is then threaded into the epidural space. An epidural can be used for both vaginal and cesarean births. Epidurals are not recommended for women receiving anticoagulation therapy, have a history of spinal surgery or spinal abnormalities, coagulation defects, hypovolemia, or infections. Complications include nausea and vomiting, hypotension, fever, pruritus, intravascular injection, maternal fever, allergic reaction, and respiratory depression. Effects on the fetus during labor include fetal distress secondary to maternal hypotension. The likelihood of hypotension can be minimized by assuring that the woman avoids a supine position after the epidural catheter has been placed. Combined spinal epidural analgesia. Another epidural technique is combined spinal epidural analgesia, or CSE. This technique involves inserting the epidural needle into the epidural space and subsequently inserting a small gauge spinal needle through the epidural needle into the subarachnoid space. An opioid without a local anesthetic is injected into this space. The spinal needle is then removed and an epidural catheter is inserted for later use. It has a rapid onset of pain relief within 3 to 5 minutes that can last for up to 3 hours. It allows a woman's motor function to remain active, and her ability to bear down during the second stage of labor is preserved. This technique provides greater flexibility and reliability for labor. Complications include maternal hypotension, intravascular injection, accidental intrathecal blockade, post-dural puncture headache, inadequate or failed block, maternal fever, and pruritus. Hypotension and associated fetal heart rate changes are managed with maternal positioning, intravenous hydration, and supplemental oxygen. General anesthesia. General anesthesia is typically reserved for emergency cesarean births when there is not enough time to provide spinal or epidural anesthesia, or if the woman is contraindicated for the use of these anesthetics. It can be started quickly and causes a rapid loss of consciousness. General anesthesia can be administered by IV injection, inhalation of anesthetic agents, or both. All anesthetic agents cross the placenta and affect the fetus. The primary complication with general anesthesia is fetal depression, along with uterine relaxation and potential maternal vomiting and aspiration. Physical examination. The physical examination typically includes a generalized assessment of the woman's body systems, including hydration status, vital signs, oscillation of the heart and lung sounds, and measurement of height and weight. The physical examination also includes the following assessments: fundal height measurement, uterine activity, including contraction frequency, duration, and intensity, status of membranes, whether they are intact or ruptured, cervical dilation and degree of effacement, fetal status, including heart rate, position, and station, and finally, pain level. These assessment parameters form a baseline against which all future values can be compared. Laboratory studies. On admission, laboratory studies typically are done to establish a baseline. Although the exact tests may vary among facilities, they usually include a urinalysis and complete blood cell count. Blood typing and Rh factor analysis may be necessary if the results of these are unknown or unavailable. Screening for hepatitis B, streptococcus, HIV, and other illnesses may also be performed. Group B streptococcus is a gram-positive organism that colonizes in the female genital tract and rectum. It is present in 10 to 30% of all healthy women. These women are asymptomatic carriers, but this can cause a disease of the newborn through vertical transmission during labor and horizontal transmission after birth. The mortality rate of infected newborns varies according to the time of onset. Risk factors include maternal intrapartum fever, prolonged rupture of membranes, previous birth of an infected newborn, and bacteria in the urine. A woman being admitted to labor and birth in the hospital should have a rapid HIV test done. To reduce perinatal transmission, women who are HIV positive are given a drug called zidovudine, or a single 200 mg dose of nevirapine at the onset of labor. The newborn is treated with zidovudine orally, and this should continue for 6 weeks. It is recommended that women who are HIV positive and have plasma viral loads of more than 1,000 copies per milliliter be counseled regarding the benefits of elective cesarean births. Typically, blood pressure, pulse, and respirations are assessed every hour during the latent phase of labor. During the active and transition phases, these are assessed every 30 minutes. The temperature is taken every 4 hours throughout the first stage of labor and every 2 hours after membranes have ruptured. This is done to detect possible elevations that may indicate an ascending infection. Vaginal examinations are performed periodically to track labor progress. This assessment information is shared with the woman to reinforce that she is making progress toward the goal of birth. Uterine contractions are monitored for frequency, duration, and intensity every 30 to 60 minutes during the latent phase and every 15 to 30 minutes during the active phase, as well as every 15 minutes during the transition phase. When the fetal membranes rupture, spontaneously or artificially, there is an assessment of the fetal heart rate, and the amniotic fluid is checked for color, odor, and amount. During the latent phase of labor, the fetal heart rate is assessed every 30 to 60 minutes. In the active phase, it is assessed every 15 to 30 minutes. Thank you for watching.